So here we are. We're going to talk about some updates in the ALK space. I think for me personally, just the end of 2019 really changed my thinking a lot. So what had happened is we had a number of next generation ALK inhibitors: ceritinib, alectinib, brigatinib, lorlatinib, entrectinib. And we all had some of their data given in the post-crizotinib setting, so in the second line setting. And the amazing thing, though, is that the drugs were entirely reliable. You could repeat the same experiment in different trials in different countries, and they would all give you almost exactly the same median PFS for that drug. So alectinib was reliably post-crizotinib in the kind of 7 to 9 month median PFS range. Ceritinib was reliably in the 5 to 6 month. And the standout winner was brigatinib. So brigatinib in 2, and in fact, as I'll tell you, 3 separate studies reliably had a median progression-free survival of between 15 and 16 months. And so that said, okay, we don't entirely understand it. The preclinical modeling didn't entirely explain this, but that looked like the one to watch. So then these things were starting to move into the first line. That's what happens with drugs. You know, you develop it in the kind of acquired resistance setting, you feel comfortable with it, and then you try and displace the old king. So we got ceritinib was compared to chemotherapy, and sure, it was better than chemotherapy, but nobody was that excited about it. It was fairly toxic, and I think ceritinib doesn't even have a sales force. That's sort of gone away. Alectinib in the ALK study versus crizotinib, I think, really made people sit up and take notice. You got a median progression-free survival running in the 24 to 34 month range, depending on who exactly was doing the readout. And the hope was, if brigatinib looks better than alectinib post-crizotinib, what would brigatinib look like in the first-line setting? And we had a very early readout in the World Conference on Lung Cancer in 2018, where it was clearly better than crizotinib, but the data was very immature. There was only about 11 months of follow-up. And then in the fall of 2019, there was a longer follow-up presented at ESMO Asia. And I've got to say, I was somewhat disappointed by the results. The efficacy results were almost exactly identical to ALK's. And you can measure efficacy in different ways. But if you looked at the independent radiology review assessment at the same time point, the median progression-free survival was like 24 and 25 months, respectively. If you looked at the 2-year non-progression rate by the investigators, it was almost exactly the same between the two. If you looked at the hazard ratios, they're almost exactly the same. And the only thing that was subtly different was the point estimate of the median progression-free survival by the investigators. And, it was about 34 months with alectinib, and it was probably about 25 months with brigatinib, but the confidence intervals overlapped. Now, if you and I are trying to develop these drugs, what we do is we look for the endpoint which is different that favors our drug, and then we talk about that. So you'll find that the alectinib people will talk an awful lot just about the point estimate of the median in the investigator. But if you look at every other endpoint, they're almost exactly identical. And that was a big surprise. The way I've been able to think about it is, my assumption is, when you go in post-crizotinib, some mechanisms of acquired resistance have already set in. And then if you go in with a drug that works on those, the cancer has to sort of go back along the same pathway, and you gain a benefit from that. If you go in the first line setting, when these things are not established, if your drug suppresses 50% of mechanisms or 60% of mechanisms, you're still leaving a big enough hole that the cancer just adapts and goes around it. And the ultimate difference between these drugs isn't manifesting in the first line setting. So, I've tended to use the term kind of like clonal equipoise, such that, in the first line setting, the cancer just sort of moves around it. It's much more pluripotential. Now, if that's true, you then have the situation, you go, okay, so which drug do I choose? So if we just had the first line data, then it's a straight toss-up between alectinib and brigatinib. Almost identical efficacy, sure. There's a few differences in terms of the tolerability. We can go into that in just a second. The pill burden is different. 8 pills a day with alectinib, 1 pill a day for brigatinib. Maybe that doesn't matter if you're looking down the barrel of a gun, but if you're talking about normal quality of life for several years, maybe that will matter. And then there's cost, which is sort of yet to be figured out and may vary by the health system you're in. Let me talk a little bit about safety. So you can measure safety in different ways. You can look at the adverse event rate within a study. And we all know that not every grade 3 adverse event is the same. Also, even when you're on a treatment for a very long time, even low-grade adverse events can actually be problematic. The other is the dose reduction rate. And the dose reduction rate is certainly much higher for brigatinib, it's something like 39%, than it is with alectinib, which is running about 20%. But then you have to say the dose reduction is dictated by the rules in the study. A lot of the dose reductions for brigatinib are related to asymptomatic laboratory abnormalities in the real world you may not do anything about. So one of the data that's going to be really interesting is when these drugs get licensed, what is the dose reduction rate in the real world? If you ignore an elevated CPK in the real world when the patient has no symptoms, maybe you don't dose reduce. So I think that will be interesting data to come out. And then finally, there's kind of quality of life data. And that's a hard one to interpret too, because that's a combination of your effectiveness on the cancer, but also your side effects from the treatment. In the ALK study, alectinib could not actually show a better quality of life compared to crizotinib, whereas brigatinib could in the ALTA-1L. So presumably, there are different people who will tolerate one drug more than the other. But there's something actually much more interesting going on. Because you're not just talking about viewing these things in isolation in the first line setting, because you also have to think about what am I going to do for my patient next line? And technically the drug that's licensed is lorlatinib. Lorlatinib has a license post-alectinib in the first line setting and post-brigatinib after crizotinib. But let's ignore that for just 1 second. Let's assume that if you're going to put everybody on lorlatinib, then it still comes back to a first line, shall I give alectinib or brigatinib? But if you're open to thinking creatively, there's some emerging data that brigatinib has activity post-alectinib. And it's almost certainly better tolerated than lorlatinib, which has 54% of people get some higher cognitive function, 80% of people get cholesterol or lipids out of control that they need to go on medication for. And if you just played the numbers game, you would probably do alectinib followed by brigatinib followed by lorlatinib, because the brigatinib post-alectinib data, it was one very small study that had about a 17% response rate. But now we have more than 200 patients, and that response rate is looking almost exactly the same as lorlatinib, about a 50% response rate, median progression-free survival about 6 or 7 months. But even that paradigm, alectinib followed by brigatinib followed by lorlatinib, I want to break down too, because you guys are smarter than that. This is not about just playing the numbers for your patients. The fact that you can have a brigatinib study post-alectinib with a 17% response rate and another that actually had a 70% response rate tells you these drugs don't work in everybody. And it's who you treat that influences your chance of benefit. Now, we know that there are 2 different kinds of resistance to ALK inhibitors. One is on target, other ALK mutations. And we know that lorlatinib works very well for G1202R. Brigatinib sometimes works, but sometimes doesn't. Brigatinib and alectinib and lorlatinib work on many of the other mutations. So if you have a mutation, you can probably find a drug that works. But in the last 12 months, we've also started to see the first identified second drivers, non-ALK pathways. And the reason that matters is some of them are actionable. We had seen from preclinical work from Japan, maybe a couple of years ago, that MET amplification could be a mechanism of resistance on alectinib. We saw at the World Conference of Lung Cancer last year that MET signaling through unknown mechanisms could also be a mechanism of resistance, as shown by cell lines growing which had become sensitive to a MET inhibitor. And then most recently in February of 2020, we saw a study from Mass General with 2 clinical cases, one with a MET fusion, one with high-level MET amplification, again responding when a MET inhibitor was added in to the ALK inhibitor. And what MET inhibitor are we tending to use as our workhorse? Crizotinib. Crizotinib, famous for being an ALK inhibitor and a ROS1 inhibitor, but is also a MET inhibitor, and you combine it in there. I think what people are hoping is that the next generation MET inhibitors like tepotinib or capmatinib may also jump into that fray. But what I'm doing in my own practice now is, sure, start on alectinib, biopsy them when they progress, make sure that my analysis includes MET FISH analysis. That's the best way for looking at MET amplification. If I find it, I know what to do. I'm going to be adding in a MET inhibitor. If not, I'm probably either going to play the numbers game, brigatinib followed by lorlatinib, or look at a specific ALK mutation I see and choose a drug based on that. And if none of that works, it's about pemetrexed-based chemotherapy. So for me, I've gone through this evolution of thinking just in the last 12 months based on being surprised by what happened in Alta 1L, having to regroup, and then figuring out a plan.